Hey everyone, we've got another heart today. The heart would have sat roughly in the chest like this, with the anterior surface coming out towards the screen, posterior surface towards the turntable, left over here, right over here, head or superior over here, and the legs are inferior down here. And you'll see that the trachea is still attached, and the lungs are still present on this specimen as well. But why don't we go ahead and start off as we usually do, which is finding what appears to at least externally be the right atrial appendage. And here we find an appendage that is broad-based, triangular, or pyramidal in shape, consistent with the morphologic right atrium. And we see that there's already evidence that there was some sort of an atriotomy done beyond. So why don't we go ahead and open the heart here. And when we do that, we find that there are, in fact, pectinate muscles that spill outside the confines of the appendage, consistent with the morphologic right atrium. And we also find the connection of the superior caval vein to the superior aspect of the right atrium. So here's the superior caval vein that drains directly into the roof of the morphologic right atrium. As we look around, we also find a large atrial septal defect in the oval fossa, so an oval fossa type atrial septal defect. And then here we find the mouth of the coronary sinus. And here is the coronary sinus itself. The probe is going through it. So here's the mouth of the coronary sinus, and here is the tendon of Totaro. So obviously, whenever we see the tendon of Totaro and the coronary sinus, we've identified two of the three bounds of the triangle of Koch, and the other one is the right atrioventricular junction here. So at the apex of the triangle bounded by the right-sided atrioventricular junction, the mouth of the coronary sinus and the tendon of Totaro is where we would expect the atrioventricular valve to live. So in this heart, we would expect the atrioventricular valve to live somewhere here. Now, as we look at this right-sided atrioventricular junction, we do find what appears to be an atrioventricular valve, 1 leaflet, 2 leaflet, 3 leaflets, but quite small. And this valve does seem to have direct septal connections, so it does appear to be a tricuspid valve, but a tricuspid valve that's quite hypoplastic. It leads to a ventricle that's also quite hypoplastic and quite muscle-bound. And we don't really see any sort of an RV outflow tract. And you can see a few cuts have been made here to kind of figure out where the right ventricular outflow tract is, and there really isn't one. And you see that the ventricular septum itself is intact. So it looks like we're dealing with pulmonary atresia, intact ventricular septum, and here's the hypoplastic tricuspid valve. So why don't we go and try to find the pulmonary trunk. And this appears to be the pulmonary trunk here. Okay, so here's the pulmonary trunk that's going back to that rudimentary or hypoplastic right ventricle. And then here is the left pulmonary artery. Okay, that appears to be fed by an arterial duct. And then if we try to find the left pulmonary artery, right behind the superior caval vein, we see what appears to be a left pulmonary artery. But this, interestingly enough, appears to be anastomosed to the ascending aorta. So it appears that we have a left pulmonary artery that is supplied by an arterial duct. And then we have a right pulmonary artery that has been anastomosed directly to the ascending aorta. And you can see suture line here. And you can see suture line here as well. Okay, so it does appear that this didn't necessarily naturally arise there, and this might have been a surgical procedure that was undertaken. So far, it looks like we're dealing with pulmonary atresia, intact ventricular septum with a very small hypoplastic right ventricle that's quite hypertrophied and there's a very hypoplastic tricuspid valve. Here's a posterior aspect of this heart. We'll go ahead and open up this atrium here. And here we find a smooth-walled atrium. Here's the orifice to the appendage, which appears externally to be a left atrial appendage, and all the pectinate muscles are confined within the appendage itself, consistent with a morphologic left atrium. Here we can see the atrial septal defect. Once again, it's an oval fossa type atrial septal defect, and we can see some pulmonary veins coming back to the superior aspect of this left atrium. We then find that the left atrioventricular junction is guarded by a 2-leaflet atrioventricular valve, and that this valve has no direct septal connections consistent with a morphologic mitral valve. So here's the anterior leaflet, and then here's the posterior leaflet of the mitral valve. This ventricle itself has fine crisscross trabeculations consistent with a morphologic left ventricle. Then we come out to the outflow tract here. We do find a arterial valve here with 3 leaflets, 1, 2, 3, consistent with a aortic valve, and you can see here the coronary arteries arising from within the sinuses, and you can see that there is mitral aortic continuity. Once again, to point out that the arterial valves, aka the semilunar valves, don't have a true round or oval annulus. That is kind of a man-made structure. Its true annulus is this crown shape because the fibrous valvar leaflets themselves are interposed by myocardium, except in the case of the aortic valve, which part of it is supported by this fibrous continuity with the mitral valve. Here's the ascending aorta. You can see the ascending aorta is very big compared to the pulmonary trunk, obviously, because of the pulmonary atresia. Here we find what appears to be the left pulmonary artery anastomosed to the ascending aorta. Here's the transverse aorta, and then here is the descending aorta, right? And here appears to be the arterial duct that was then supplying the left pulmonary artery. So once again, this heart appears to have pulmonary atresia with intact ventricular septum. There's a very hypoplastic tricuspid valve here. And the RPA has been anastomosed directly to the ascending aorta surgically, and the left pulmonary artery arises and gets fed by an arterial duct. So this heart has usual atrial arrangement with an oval fossa type atrial septal defect with concordant atrioventricular connections with a hypoplastic tricuspid valve, right-handed ventricular topology with a hypoplastic right ventricle, concordant ventriculo-arterial connections with pulmonary atresia, a patent arterial duct supplying the left pulmonary artery, and then a right pulmonary artery that has been anastomosed to the ascending aorta.